course going. Here I would request my panelists. So the course which we are going to take up today is Errors to Expertise, Decoding Phacoemulsification Mistakes. This is going to be a highly interactive session wherein the video is going to start, a mistake will come up, the video will be paused, the panelists will discuss why it happened, what they would do, and eventually the speaker would continue how he did. So this is going to be a highly interactive session, and luckily we have with us Professor Amar Agarwal. If you could come to the dais, sir. Dr. Gaurav Luthra. Dr. Kumar, doctor. So I would request, if any of you at any point of time feels that there is something which they would like, Dr. Tushya, please, would like to add something at the end of at that particular question or that particular talk, he may come up and we can take it further. So all said and done, the plan is to have a real interactive session wherein each one of us can gain a lot. So I think we still have a minute or so, or should we just start it, sir? It's just 2:57, or should we wait for 3 sharp? Yeah, we should wait. Yeah. So the panel is split about it, whether we should start. Yeah, so I think we can start, so we'll have question answer. So Dr. Kumar Doctor would be talking about biometry to some extent and IOL mishaps, how he has managed them. So over to Dr. Kumar Doctor. He doesn't need any introduction. He's from Mumbai, the second generation into ophthalmology, has presented all across the world in all forums at all levels. Over to Dr. Kumar.
Hello, yeah. Good afternoon, everybody, and thank you, Dr. Rohit Om Prakash, for allowing me to participate in your course. Now, as you all heard, that it's video interactive, and my topic is biometry. So that itself puts it off. But I will show some part of biometry, what it is crucial and what we are doing in our setup now. And then I'll show some mishaps in IOL. So we all understand that today modern cataract surgery is 2020 and beyond, because our patients have made it. All cataract surgeries are now refractive surgeries. They are no longer pure cataract surgeries. So on average, what they have seen statistically, that 78% of patients are plus or minus half ophthalmologists, 6% of surgeons get 84% or better, and 1% of surgeon gets 92% or better. So you can rate yourself in your post-op results as to where you really stand if you're checking 6/6 and not 6/9. But when it comes to short eyes and long eyes, the big problem begins. In normal cases, we are in 95% as far as biometry is concerned. So there are two important things, biometry and formula. IOL calculation, the maximum error comes from corneal keratometry, which is 27%, IOL misalignment 14%, IOL tilt 11%, and angle kappa 7%. So now you need to address each part of this as to how you can avoid it. So there's no doubt that contact biometry should be banned. If you want to do biometry ultrasound, always do immersion and do not do contact, and that will remove half your problems. And of course, intraop aberrometry is no longer available now, but optical biometry is what we should technically do for our patients. Of course, the cost goes up, we have all the other headaches, but no doubt that your results will drastically improve. We have lots of machines for optical biometry. You have IOL Master, you have A-Scan, Pentacameral, Aladdin, Galili, so many things. But I went ahead, you can see the whole scan. I had a Nidec AL scan. I've also used the Zimmer G6. I've also used the IOL Master. But ultimately what I bought was the Anterion. So it's the all-in-one figure which does everything. So when you come to biometry, you can look here that you can compare two eyes together. you get corneal aberrations in one shot, and you get your white to white in one shot. So you have information of both eyes that is coming parallel at the same time. So that's one big advantage. And you can also get your corneal wavefront at the same time, so you can know if there are any aberrations. At the same time, you see parameters like IL calculation, corneal map, angle kappa. All this information is coming through one shot, through one information. So you really don't need to search through different instruments, and that's the one big advantage that you have. And of course, it has a Barrett built-in suite, and now we all know that we are using the Barrett 2 universal, and you can put multiple formulas here. So you can see I put an SRK2, Barrett, and you can put whatever you want. You have 4 options, and 4 calculations will pop up at the same time. So what important information I'm getting here through one instrument is corneal wavefront, astigmatism. It's calculating total corneal power. So that's another big advantage. So if you have an optical biometer which doesn't do total corneal power, do not look at it. You need total corneal power, because some of us have been doing LASIK since 1999. All those patients are developing a cataract, so you will have to look at it. Coming to formula and which one of them is good, you have lots of options. But we all know that if you look at the last one, which is Barrett, it does axial length, K reading, ACD, white to white, and lens thickness. So suddenly lens thickness and ACD is very, very important besides axial length and keratometry, because that actually will determine where your IOL is really going to sit. And this comes a problem when it comes to small eyes or long eyes. And this is just one example of how you can see anterior segment division of large, small, and medium compared to axial length, and you can classify them accordingly. But when it comes to long eyes, you can get an error. But when it comes to short eyes, you get a sudden surprise myopia, because you have a shallow anterior chamber. So some of you can do this. I've suddenly started doing this study that post-op I'm doing axial length measurement, and your lens is actually sitting 2 millimeters ahead, and that's the reason why sometimes even the Barrett formula does not work perfectly. Now coming to new generation formulas, you can see here the Barrett 2 covers everything, short, normal, and long, and you can have Hoffer Q for short eyes. So if you have a very high hyperopia, prefer Hoffer Q, otherwise do the Barrett 2. Just one example of an anterior chamber which is very, very shallow, hyperopic LASIK done. So you can see the anterior chamber is 1.92, lens thickness is 4.37, white to white is small. We did multiple measurements. So I also do the Barrett, I also do the Hill RBF, which is artificial intelligence, and the conclusion was to put a 31.5 diopter IOL, and we went ahead and did a 31.5 multifocal IOL with a 3.25 ad, and the result was very, very good. Suppose the patient undergone myopic LASIK. So a big advantage here, you don't have to really worry. Again, put in all the data. You can see normal ACD, lens thickness of 4.37, but a long eye because it's a myopic LASIK. Again, I did an I did all the other formulas, the Hegis L and the Barrett 2K, etc. And even the Hill RBF, and the calculation was, so we have 3 informations. We have from the ACRS formula, the ACRS Anterion, and we have even the IOL master power. So here you can see that IOL master says 22, Anterion says 22. I went ahead and put an Anterion 22 diopter, and what I got was an excellent result. So I went ahead with put a synergy, a PCIOL, and patient did very, very well. So this is just as far as just one example of a small eye, that this is axial length, which is a micro-ophthalmos with axial length of plus 12 diopter, a normal ACD, and PI done for safety, normal posterior capsule, topography done, just to show you white to white, ACD 2.68, and lens thickness normal. But when you look at the axial length, 14.85. So this is a very, very small eye. I went ahead, this was, of course, I've done all the research, and I went ahead at just one video I'll show of a 65 diopter IOL that I put inside. So this is a 65 diopter IOL made. Challenges you all know, we took all the precautions. I did a femto, and you can see that I went ahead, removed the CCC, never allowed the chamber to collapse, did a bimanual IA because a young patient, did a large incision. You need a 3.5, but this is a 65 diopter IOL manufactured. You need a 3.4 millimeter incision, put the lens in the bag, and then dial the lens into the bag. And you'll be surprised the post-op result was minus 1.5 with a 1.75 SIL. Coming to IOL mishaps, this is one of the toughest cases where it's 14 years back. I had only operated this patient. That time, some of you might know, this was a company called Acridic, made 733 and 7372 IOLs. And here if you see, no other sticker was available. So this you can see the lens and you can see an eyes. Now patient was allergic to Tropicacil Plus. So when I dilated him, all he dilated was mid. And you can see the lens sitting there, and there was a YAG opening. Okay, so this was a multifocal IOL, lens is subluxated, and the patient says, I want multifocality. Okay, so this is all we did. So now coming to this surgery, you can see that here the patient's lens is sitting down. When this happens, we don't have much choice. So here under topical anesthesia, what I'm trying to do is put a intracameral epitrate, so pupil dilates, and when the pupil dilates, you can see beautifully the central YAG opening that is done. We put methyl always on the cornea so to prevent regular hydration of the cornea. Once that is done, put triamcinolone acetate into the anterior chamber, go ahead and do your vitrectomy right in the center, so that all the vitreous that was coming out, just make sure that that is all removed, and that brings your disc, which is a multifocal IOL, into the anterior chamber. Now, whenever you want to explant something like this, it's very, very important that you hold the disc, okay? So you need micro-grasping forceps, and then once you hold the disc from one side, and then you need micro scissors, and you don't need to cut through and through. As you all know, you cut only halfway, and then use the incision as a fulcrum, and like a Pac-Man, you just hold one end and rotate the whole lens out. Now you can see that there are two haptics. One haptic is in the sulcus, one haptic is in the fused anterior posterior capsule complex. So you can see that it is lying there. So this is how I remove the optic, and once that is done, I remove the other haptic which was floating in the sulcus. And now the question is, the patient wants multifocality. Here I'm just seeing if there is any adhesions in the periphery. Luckily there are no adhesions. Went ahead and did anterior vitrectomy. Once this was done, I just fill in again viscoelastic. So now only 3-piece multifocal IOL is the technique that is available in the market today. So one thing we can do is 100% inject this lens into the sulcus, and because my anterior posterior fused capsule is still existing, we have to make sure that this 3-piece multifocal IOL should also not decenter in the future. So what we go ahead and do is that dial the lens into the sulcus, and once that is done, I'm going to optic capture this. So you can see that I'm optic capturing into the fused anterior posterior capsule complex, and this will never allow this lens to decenter in the future. So I still gave patient multifocality, and the patient was quite happy. Now this patient is very interesting, no history, came to me with second attack of high IOP, pupillary block, operated elsewhere just 12 days back. Okay. Now the question is, of course you control the pressure, etc. I don't have more, but I'll just show you what I did. So you can see this. Can anyone say what do you think is happening here? High pressure. You can see this is all the pupil dilates, and patient came to me on the 12th day, second episode of high pressure. Give him medicine, the pressure goes down, leave it, again the pressure goes up. Anyone can say something from this?
Lens is upside down.
Perfect. So the lens is upside down. So I go ahead and see what the hell is happening. Dilate the pupil with epitrate, go ahead, put in viscoelastic below the IOL, again put in viscoelastic and bring it in the front. So I got the haptic out and got it in the anterior chamber, okay. And now question is about the other haptic, got that also into the anterior chamber, and now I put in more viscoelastic below the IOL, okay, and more viscoelastic above the IOL, and then I flip this IOL in the AC and then put it back into the bag. Okay, so now the IOL is dialed into the bag, and this patient, luckily no injury anywhere, did very, very well. And now the second haptic is just dialed into the bag. And actually this solved all the problem, and all the episodes were fine, never had any problem. Just a last case, the patient came like this. Now what are you going to do? Questions? Sorry. What is the next? This is all that the pupil dilates. Now what device will you use to dilate this pupil? I'm under topical anesthesia. So what will you do? Anybody from the audience? So you can see a little bit of the IOL. You can see a complex behind. You can see this is all that the pupil really dilates. So will you use a Malugan ring or a B-hex ring? Yes or no? Someone said no. Intracameral, we'll put and see. It won't help much.
Iris hooks.
Perfect. So why iris hooks? Because we need more exposure. So we really need to know what's happening all around. So I go ahead and put iris hooks. I put 3-4 iris hooks. And now that gives me good enough exposure to understand what's really happening in this whole complex. So you can see that the lens is decentered or subluxated. Now the question is, we want to recenter this because it's a 3-piece IOL. It's in the right direction. But how do we center it again so that it doesn't decenter back? So now I'm trying to bring the IOL back into the center, but I want it to be in the optical axis. So now I use a marking, Rexis marking device. So we mark the center, tell the patient to look in the center, And now we need to support this lens. So principally, I'm doing the same thing, putting in viscoelastic from behind the IOL, going ahead and doing a small vitrectomy, again that anterior posterior capsule lens complex. So here, first time when I did it, it turned out to be a little small. So you need at least a 4 millimeter opening to do a 6 millimeter optic capture. 4.5 will also be sufficient. So here I made a small opening first. I realized that I could not do an optic capture, then enlarged it a little bit to be able to slip in the optic of the IOL easily inside. So now I got one end of the optic of the IOL inside, and then coming to, so you can see that I'm slipping one end of the optic just behind that complex, and then at the same time I'm slipping in the upper end of the optic just behind the complex. So you can see that it's just slipped in, and once that is done, the IOL will always center and remain in the center. Here you can see I'm re-engaging. You can see the whole fisheye appearance. Remove the haptics, and these patients do very well. Thank you all for your attention, and thank you, Dr. Rohitam Prakash.
Dr. Kumar, I would like to ask you on this case, like, what was the primary reason for decentration of this IOL?
I think you can realize that the lens was lying in the sulcus,
Okay.
and some zonules inferiorly must be compromised during the primary surgery.
Okay.
So then ultimately over time these lenses subluxate a little bit and they move downwards.
Okay.
Luckily for us that we can now refix them, so there's no other fear.
Dr.
And
Amar would definitely do a glued IOL on that. What do you have to say?
David, please say glued IOL. Please!
Amar makes his own glue.
So we move on to Dr. Rohit Om Prakash. He would be talking on RCA, root cause analysis of mistakes during phacoemulsification.
Yeah. Thank you, Dr. Tushe. So this is the case 1, which is a routine cataract, and the patient has nucleus sclerosis grade 1. The pupil size is 6.5. The biometry shows that there's no extreme length of the eye in any case. The resident started the surgery. So in this case, you will find that she's doing hydrodissection in a very slow manner. Everything for her, is being done in a very cautious way. So she starts the surgery, and while doing the surgery, she's going on, and suddenly she realized that there's a punch. Now what next? Dr. Gaurav, how would you, go about it?
So first thing is you have to suspect that there's been a PC break over there. And, if you do wishful thinking and you think that, I should have got away. So I think you should pause, don't switch off the infusion. Keep your infusion on and then start thinking whether, maybe zoom in and see if there is you can see something broken there. If you can't, then I would actually suggest that, keeping the infusion on, go and inject viscoelastic from the other side port and get your chamber stable. And then, try to identify if you actually went into a break. Now, the problem is that if you did have a break, then you're in a situation because right now you can't even go and, convert it into a rexis or something like that because there's no space over there.
No space.
Then it'll just be wishful thinking. So then you have to put in a good viscoelastic, maybe something like Viscoat to plug that small gap till you can get, a better separation. So then you would have to proceed assuming that you have a PC break over there, and then without any major manipulations, hope to get one small chunk out so that you can have a better visualization of that area and deal with it. Most often you can get away with it if you don't have fluctuations in the chamber and make enough space for you to be able to see what's happening and replenish viscoelastic, push some viscoelastic, high quality, dispersive viscoelastic, which will stay over there and plug that gap. And you may be able to complete the surgery as well, but be prepared. And of course, an IOL scaffold, if you had a smaller piece, you could have, brought it out of the bag and put an IOL scaffold.
Absolutely.
Rohit, 1 minute.
Yeah, absolutely, yeah.
Rohit?
Yeah. David, your take on it?
Yeah, I think the first thing is you probably have to take over instead of the resident. But I would assume that you have a break. You may not. I think you can go ahead and either crack it or chop it. And if you can get it into heminuclei or quadrants, you can elevate them out of the bag so that as you try to remove it, you're not putting more pressure that would expand the possible rent. But
Just
the
I'll
minute
add-
you see vitreous, of course, you have to stop.
I would like to add one more thing in this thing is, because if it starts sinking, I think I want to mention David's name here. David Chang Richard Packard and Kelman brought out the PAL technique. So, if it starts sinking, I would suggest use the PAL technique to bring it up. If you're lucky, it comes out, no problem. But if it starts sinking, please use the technique which they brought out, and it's a fantastic technique.
So she continued, but she was oblivious of what she had done. Suddenly, she realized that something is wrong. Her hands are trembling, and she maintained what Dr. Gaurav said, stable chamber settings, and she sent an SOS, and I asked her to send the patient to me. So that done. So what next? Convert IOL scaffold or continue phacoemulsification? Well, the plan for me at that point of time was that in this patient, the CCC was intact. So I thought I'll use low IOP to my advantage. I would not do any rotation because rotation should not be done in such a situation. Implant IOL if possible, or change to IOL scaffold if required, as has already been told. I would be using the low IOP phacoemulsification as has been shown by Bob Osher and Abhay Vasavda. So I would be, using IOP of around 20 or so. Max which I would be going on would be a supraphysiological, which I call IOP between 23 to 34 to my advantage. So the patient was shifted. I did separation, not extensive separation. Since hydrodissection had been done, it had been separated. I did exactly what David said, tried to pull it out, which I was able to because the adhesions in this grade 2 cataract were not that profound. Did supracapsular emulsification in this moderately hard, not moderately hard, soft cataract, and the phacoemulsification was completed for one heminucleus. At this point of time, because of low infusion pressure, what was happening was the anterior hyaloid phase was not being broken, as has been shown by Abhay Vasavda, where high IOP, high fluidic pressure can break the anterior hyaloid phase. So everything was being done, and the posterior capsule was not being pushed behind, and the emulsification in this patient was eventually completed. Once that was done, I did what Dr. Gaurav said, that maintain stable chamber settings, because you do not want, with the collapse, with the chamber shallowing down, that the anterior hyaloid phase should break. So once that was done, the stable chamber settings, typically a bimanual should have been done because you want to separate the different levels of irrigation and aspiration. I retracted the, the sleeve, and this is the Gills and the James P. Gills from Florida. His technique of dry aspiration is being done with a 25 gauge cannula. So that was done. Once that was done, then I thought of implanting. I could have rounded off the posterior capsular punch which was there, but instead I thought that I'll go ahead, and I did an optic capture, and the surgery was completed. So there's another learning in this patient. So this was a highly demanding patient who had a posterior polar cataract with pre-existing posterior capsular defect. He was highly demanding. There was a coexisting astigmatism, and the patient wanted toric intraocular lens. On anterior segment OCT, you can see there's a moth-eaten appearance. So it was almost conclusive that it is a pre-existing defect. The surgery was started. The surgery was started using low parameters, 28, but we usually come down to 28 or 30. And once at this stage, I realized that the rent was there. So stable chamber settings now. So what would you do? Would you, Dr. Kumar, at this point of time?
No, I think only thing different maybe I would have done is I would have done a femto in posterior pola where there's a pre-existing rent. Another thing is many times when there's a pre-existing rent, the surrounding area is quite fibrous, so it's quite strong, so that actually gives you support. But this rent has happened during your last stages, so there's very little cortex remaining, so you can still plug that area, put viscoelastic on that, go ahead and do your bimanual IA, and you can put the lens again with an optic capture. So you can put it in or reverse optic. But here reverse optic, because this looks like a linear tear. Yeah. So it'll be tough to put a lens horizontally because you can't put it vertically. Then I might put it in the sulcus horizontally and do an optic capture.
David? Yeah.
David, would you go ahead putting a toric IOL in this case?
And how much power of a toric does she need?
It was not the extreme height.
Yeah, yeah. So, I think if the toric isn't on axis, you haven't really accomplished anything. So I think you certainly can't argue with a monofocal 3-piece, and the sulcus maybe do astigmatic keratotomy while you're there. In the United States, if you had a polar and you know in advance that the patient may have a PCR, we will tell them about the light adjustable lens where we can put that in and treat anything. And if you really needed like a T7 or a high power, you could do reverse optic capture.
Absolutely. So I just continued stable chamber settings, did IA, because once that was done, stable chamber settings again, because of the low IOP which I usually use in these posterior polar cataracts, I give it a try whether I can pull the end of the tear back or not. I have gone through, created a small incision at the side so that the chamber settings are stable, and I was able to round it off. So once I was able to round it off, I thought that I might as well try a toric lens in this situation, as David has taught you. You rotate it to the axis where you want to, and once you're around that, you just flex it in, mindful of the fact that you are just behind the capsular axis margin, and push it in and flex it again and push it in. I was lucky this time, because at times you really cannot. Had I not been able to do that, I would have done a reverse optic capture in that patient. So this is another situation wherein it is a posterior polar cataract. It's a very old movie. I'm going ahead, doing my bit of sculpting, pushing the nucleus, which should not have been done. It's a very deep chamber, trying to create a situation where I would do cross chopping, and I crossed everything, the limits, and you will find that suddenly it has gone behind. So here, glued IOL and everything which Dr. Amar said would have been feasible, but I would like to show that what you can do to avoid such a situation. So why did this happen? Because there was over deepening of anterior chamber, there was pushing while sculpting, and there were wide separational forces. The high fluidics were the deterring factor, which created a situation in which everything went topsy-turvy. So the plan is usually in our cases is that we use low fluidics, stable chamber settings to our advantage, appropriately sized incision, small rexes, no hydro procedure, no rotation of nucleus, and avoid separational forces. So now I would like you to see how, by using low IOP, we can befriend the anterior hyaloid phase. Here I'm trying to create an oval rexus, as has been advocated by a very close friend of mine, Dr. Kiranjeet Singh, because that gives the advantage of both small and a large rexus. Sculpting being continued, total division is what we aim for, and now the chopping is being done, and we have totally separated nuclear fragments, cross chopping, as has been shown by Ronald Yaw, that is being done. So once you have totally separated it, that is the time when I'm pulling it out. Now with a small maneuver, after totally separating the nuclear fragment, now I'm trying to totally separate it. I'm doing the back flip, pulled it up, and I was able to emulsify, one half of the nuclear fragment. So that's done. So back flip, whatever you want to call, you can do it, and that completes, one half of nuclear emulsification. The IOP, you will see, has been further reduced to 20. So there is low infusion, no, pushing back of the posterior capsule, anterior hyaloid phase, the probability of which is remote, is very less. Now I would like you to focus on these three small nuclear fragments. With the stable chamber settings, the anterior hyaloid phase is acting as a friend. It is not acting as an enemy. So the nuclear fragments would be going, bouncing on the anterior hyaloid phase, and they would be coming back. So using these fluidics with stable chamber settings, you are able to transform the foe into a friend, and you will see while this is being done in a very guarded way, these three nuclear small fragments would not go back whatsoever. So the process is continuing, and this is the last piece, stable chamber settings. These three nuclear fragments are already there. So the Gill's technique of dry aspiration would be done by us. You know, one of the nuclear fragment will come out, small nuclear fragment. What will remain are the two ones. And then, you know, dry aspiration. Once that is done, so this is very handy. You know, I've been using it, David Wright, since 1990, this Gill's Welch technique of dry aspiration. So this has really helped. So once that is done, so that nuclear fragment will not go behind because anterior hyaloid phase is taking care of it. The second is there, so these two pieces are now out. So this is, you know, there are so many videos I have, so but I think I'll ask Dr. David, would you like to take over? Yeah.
Any questions from the audience for anybody?
I think these fluidics have really helped. Dr. Gaurav, are you using Centurion in all, or are you using, you have one in one, you have
one
Signature
OT
Pro,
have,
and
yeah.
in the other you have?
Yes, so I have a Centurion with Active Sentry in one OT. The other OT I have a Signature and a Veritas. So, but you know, even with the Signature and Veritas, I use IOP, IOP of 30, which is about 40 bottle height. So I get pretty good, fluid chamber stability even with that. So frankly, now I'm equally comfortable with both the Signature or the Veritas and the
So
Centurion.
Veritas, the fluidics have.
So they haven't yet been able to give us those new packs which they're supposed to give, which will improve the fluidics. But right now with the Signature packs, we still manage. So I was just wondering, Dr. Rohit, in that case, I mean, I was like spellbound how you manage that, because any time those nucleus fragments would have gone back and you managed to keep it light right till the end. I'm just thinking that for a surgeon who is not so, you know, kind of controlled with the fluidics and the movements and shallowing of the chamber, I felt that we could have even put in a scaffold at that point, you know. Absolutely. So for a surgeon who is not adept at fluidics like you are, maybe the message could be that, you know, put in good viscoelastic, have the nucleus kind of, you know, above the iris plane towards one side, put in a IOL scaffold, and then, you know, you have it much easier, because then this will, but it was a masterly management.
Pulling it up.
So the take home here is, for those who do not have fluidics IOP display, you can reduce your bottle height to 40. Normally you keep it 80, or if the patient is high myop, you take it to 60. In this case, you can take it down to 40, and that display is there on your screen. So you can take it down to 40, and that will reduce your IOP to around 28, 30.
But also bring down your parameters.
Yeah. Parameters, of course, have to go down parallel. Over to David.
All right. Well, I'm going to show a case where I could have definitely done things better. You know, there are about 3 seats in the first 4 rows if someone wants to come, empty seats from the back. So it's not advancing here. The keyboard is not advancing. So maybe let's try here. Okay, now it's advancing. All right. So this is a 64-year-old patient who was referred to me. They had a toric monofocal 6 months ago. And she has 20/40 uncorrected. She had a history of a epiretinal membrane with a retinal detachment in this eye that had the monofocal. She's actually referred because of the anisometropia for cataract surgery on the other eye. So the left eye has been done. She's referred for cataract surgery on the right eye. All right, so you can see she's got this large anisometropia. She's 6 months post-op. She's 20/40. Now, she had a toric lens, but she's got a lot of cylinder in the first eye that's done. And the axis that it's at is the 180 axis. So, of course, I'm curious about that first eye. And look, the true axis, at least in the anterior cornea, should be at 45. So it looks like the lens isn't exactly aligned. And so that's why she's 20/20 with a diopter and 3/4 with a T4. So of course you can go, this is one of the online calculators, and what's nice is it not only will, because you input the post-op refraction, tell you where the lens should have been, and it matches up with that 40-degree axis, but look, it tells you that if you rotated it, this would be your refraction afterwards. So that's really one of the great benefits. So I guess I'm going to ask the audience, how many people would actually suggest rotating this lens? So after 6 months, so that's the question. All right, now that one person in the audience, how about my expert faculty? Who would go? It's 6 months out, and she's actually not referred for this.
Which IOL was used at Alcon?
It's I think it's an Alcon T4.
Single piece. I don't see much phimosis around, and there's not much of PCO. So I may still attempt to put in a viscoelastic separate there, because there is a good coverage all around.
Yep.
So if you get one edge, you will be able to open up this bag. And you don't need to open up, because you need to rotate it anti-clockwise. These IOLs are a little difficult to rotate anti-clockwise. They are much easier to rotate clockwise.
Right.
In this case, you need to rotate it anti-clockwise if you need to go to 38.
Yeah,
So,
exactly.
so I would like to put in a viscoelastic in the area till 180 to 36, and in the exactly opposite direction. You don't need to open the whole bag up. Still attempt to rotate it back. Only thing is, if the rest of it, then it will correct. I think it will be possible, because I don't see much fibrosis.
All right. So we have one vote to, even though this is the eye to go in.
I would also try to rotate it by just opening up the bag by using a thin cannula and then visco cannula separating it, and then try to rotate it if I can. Yeah.
Only one thing, David, I noticed was there's some amount of fibrosis opposite to the 40 degree. So in the area of inferior whatever. So opposite to 40, there is some amount. I think the CCC there has gone beyond the optic.
Right.
And that's where it's fused.
David, why not just do a laser?
You mean of the
Cornea.
keratofractive?
Yeah.
Okay, so that's an option. Then you could leave it
Because
alone.
it's very less
Yep.
power, is the
Yep.
-1 plus 1.7567. It would
Yep.
be easily correct, I thought.
So the first thing is, I think the timer is wrong, right? I have 12 minutes?
Yeah, you go
okay,
ahead. Yeah.
Okay, 'cause so I think that the two things that are encouraging are if we could get it 140 degrees rotated, she'd be plano. And then the second thing is sometimes you see this fibrotic little small rexus at this point. This one isn't fibrotic. So I'm with you guys. I told her, I think if we rotated it, I think we could get you seeing a lot better. She said, okay. So I go in and, I see these folds there. I said, did I miss something? But so I'm just here with lidocaine, and I said, yeah, no, that's the posterior capsule, and the lens is pretty mobile. We know with the Acrosoft, you have those terminal bulbs, and it might be fibrotic then. So I'm saying I'm going to go for it. So I think I'm going to, so I'm going to go for it. I'm going to put the viscoelastic in, and it opens up pretty well. Okay, so this is what Kumar was saying. Let's try to inflate it. Amar would have already finished the PRK by this point. And look at the left-hand side, though. I'm rotating it because I need to go 140 degrees now. And can I get that haptic free? Yup. It's pretty. Look down below. Did you see that?
Yeah.
All right. Gaurav, what did we see there?
There's look like the edge of the bag. I mean, there's some zonular.
You kind of saw like the equator of the bag,
exactly,
right?
yeah.
You got to really look.
So it's a
Right
loose-
there it is. There it
It's a
is.
loose bag,
Okay,
yeah.
so all right. Well, but that haptic is free,
Put in a CTI.
and maybe I can rotate it. Okay, so this isn't looking so easy now. All right, so it's freed up. It's now worse because instead of 180, it's at 175 or 170. What would you do next? Audience? Hooks? Who would put in a CTR? All right, okay, so this is, I mean, I think that's going to solve it. Faculty? CTR? Yeah. Amar? Stop and do PRK. Amar's going to take it out and put in a glued IOL.
Amar says rotate it back to 180 and do a surface.
All right.
What I would do is like I would cut the haptics and place a new IOL in the back.
Take it out, okay.
Yeah.
But it's not fibrotic, and remember that the beauty of that formula is you know it's the right power and the right toric power. It just is the wrong axis. Okay, but you would put in a spherical or a new toric?
A new toric.
New toric, okay. Well, I'm going to, do the CTR. I think that's all it needs because it looks like about, what, 3 clock hours, maybe 4 clock hours? And so I'm smart. I know I have to kind of, not have the capsule bag bended. I kind of lost it there. Here I'm just, okay, what are we seeing down to the left? That's the bag. Whoa, wow, that's more than 3 clock hours. So I got to stop, and let's stop and reconsider now. Okay, so that was not helping. So that's my. Look, I did what you told me to do. Now, what do I do? Now, there's one problem, right? Because when you put the CTR, it's pushing the bag to my right, and there's no zonules to counter it. So how many people, maybe I should insert it from the other end, so I'm pushing the CTR into the area of weakness, and that would, all right? How many people would try that in the audience? All right, okay, seems reasonable. How many people, you wouldn't try it, but you'd like to see what happens if I try it? Okay, that was the other half that didn't vote. Well, that seemed like a good idea, so I just turn it upside down, right? Because I don't want to make another incision. And let's see how this is going. It's not really bending. Maybe if I hook it, that's a little awkward. And it's kind of, well, I can't really see what's going on. And there's a haptic down there. That's not working. Okay, I'm not going to push that any further. Okay, so this patient came for the other eye surgery. The doctor referred for the other eye. And I've pretty much got 3 clock hours of zonules. I've decentered the lens. Can I just push it back and... MR, I'm going to refer this patient now to you. Yeah. So, all right, so I've kind of succeeded in, so this is about, trying to figure out what our mistakes are. Now, think about the way CTRs work, right? I'm aiming to the left. I know the ring is going to open to my right, and it's no problem here. There's PXF with a bleb, and that's because the capsule is bending the ring and steering it in, okay? And that's what I thought I was just going to get away with in this case. Now, this is a case where I put in a 3-piece, and the round rexus became ovalized. Wait a minute. Why would that happen? Yeah, thank you. Well, it's because there's 2-point pressure from a 3-piece lens, and if the zonules on the other side aren't strong enough, the point pressure from the lens deformed it. The round rexus became oval. So I'm going to insert a CTR inside, and I do like inserting it this way, even though the haptics go the other, and watch what happens. This oval rexus becomes round. So this demonstrates the mechanism of CTR. It's distributing forces equally to all 12 clock hours at the same time. So a nice demonstration of how the rexus, the CTR works. All right, so now here's a case where I inadvertently grabbed the anterior capsule and I've created a 3 clock hour dialysis nasally on a pseudoexfoliation patient. So similar to this case, I think all I need to do is put in a CTR, right? So again, I'm just doing my cortical, oh my gosh, I created a dialysis. So what, 3 or 4 clock hours, and I know I want to try to bend the haptic, and it's kind of like this case. I'm seeing the entire equator. I don't see any zonules at all. Wow, I've got like maybe 8 clock hours there. And then look what happens, you know, that you trap the cortex with the CTR, but not only that, when I tug and strip the cortex, I'm stripping the zonules on the other 12 clock hours because those forces of stripping are transmitted to all the other clock hours. So the CTR now is making the cortical removal. I'm stripping as many zonules as I am the cortex. So this is where the CTR can cause, you know, a problem. So sometimes, you know, well, you know, so the better thing to do would have been what?
Capsule hooks?
Yeah, capsule hooks, because they're the artificial zonules. And now I know that it wasn't total negligence that I grabbed the anterior capsule. We often suck the anterior capsule when we're aspirating cortex, but the zonules keep it from being aspirated. All right, so this is what I should have done when I first saw that dialysis, is probably, you know, it costs some, it takes extra time, but as is often the case, I should have done this. These are capsule retractors in the United States. This is from Microsurgical Technologies. They are global. This is actually my modification called the Chang. I have no financial interest. It's just a double-stranded nylon loop. We made the tip closed so the CTR won't go inside. And now see what happens. I have artificial zonules. And now it's a little, so something, it's still not going in. So let me try it one more time. I filled it with viscoelastic. You don't want to push too hard, right? Because you push it right through, and then all of a sudden something kind of gave and it went, and there it is. Okay, so now remember I have to dial it 140 degrees to get this lined up, and there we go, and it's moving now. And it's amazing that, so this is a great demonstration for you now of capsule retractors. Look at the difference between with and without the capsule retractors, just the simple rotating of the lens. So they're supporting the bag like artificial zonules, they support the AP direction, and then we're gonna take them out. Okay, we finally got the lens here, and I still haven't done the other cataract, which is why she was referred, but I'm feeling okay. There's no vitreous going around there. And anyway, so we take that out. All right, so this is the best part. I get the pupil to come down with the myocall. There's no vitreous prolapsing. Whew. This is doing something she didn't even ask for. Okay, so this is what I know now. But we didn't have this back then. And this became available in the United States last November. This is the spiral CTR injector from Corsa Cantina. Dr. Shimawaki from Japan invented this. And you see there's a fixed hook in the front to grab that lead eyelet. And then when I insert this in, instead of the capsular bag bending the CTR, that little fixed hook is what bends it. And that's why it's called a spiral. And so this is very ingenious. I keep injecting it. It doesn't put any pressure on the zonules, and you basically tilt it, and then the lead haptic falls off. You tilt it a little more, and the trailing haptic falls off. And this is what I now use for my CTR injector. You know, I showed you we had the capsule retractors here, and sometimes this will get tangled up in the capsule retractors, but look how nicely this spiral CTR injector does. So it's available through Catena Corsa, it's reusable, and I use this. Now sometimes it doesn't come off, no problem, you just knock it loose. All right. So, and this is from Dr. Shimawaki, and he has this nice demonstration. So when the typical CTR injection decenters the bag. But with the spiral injector, again, there's no contact with the fornix, and so we really, if we have bad zonules, we're not relying on the zonular integrity to insert that. So in this case, by golly, she got to 20/20 just as the formula predicted by rotating it. She was very happy. And she said, I don't even need surgery in the other eye because I'll just wear a contact lens. And I'm just thinking, now why do you think the doctor referred her to me for the second eye? Remember, this is exactly what the formula predicted, which is, any thought on why the doctor referred her?
He's still your friend, no?
It's another doctor in Northern California. Yeah, maybe there was some problem with the original surgery.
Yes.
And but that wasn't part of the referral letter, and in fact, it was referred for the other eye. Yes, exactly. Now, what do you think happened in this case? So this is about mistakes and things. So I should have put in capsule retractors. I should have used a spiral CTR injector, which is now available, wasn't back then. Maybe I should have left the lens alone. Anything else? What was so different about this case? 6 months after surgery in a fairly young person, have you ever seen so little fibrosis? So the polishing, okay, yeah. Anyone in the audience have a thought on what's going on? It's very unusual, and it's on your dialysis. Yeah. Yeah, exactly, Shitra. So this is the dead bag syndrome, and I recognized it sort of afterwards. And this was only really reported in 2022. And we don't know what causes it. It may be just in one eye, but there's a complete absence of lens epithelial cells. There's no reaction, there's no fibrosis. It's associated with loss of zonules and even late bag IOL dislocation.
Does that happen so fast, dead bag?
Yeah, no one knows exactly when it happens. So these are the two. You can take pictures of this if you want to read more about it. And it's a mystery as to why it happens and when it happens. Sam Maskett first described this a number of years ago, and then this first study in 2022 was a series of them. And it's as though the lens epithelial cells just die.
They don't have it.
And so it's not really polishing too much or anything. They just die. And so you don't, and why would there be weak zonules and so forth? And as I think back on it, I can think of, I remember cases where I did a toric and it kept rotating around. Well, you go back, you get it, and it lined up, and it rotated again. And one of those patients came back, and the whole bag was dislocated. She had dead bag syndrome. So this is a cause of a toric lens not staying where it's put. And had I known that it was a dead bag, what I should have done is probably put in capsule tension segments and sutured it, because she is at risk for late bag IOL dislocation. The case is already done. We'll just watch it and find out. So anyway, how many people in the audience have seen dead bag syndrome?
So many, all of us, I think.
Before you saw this video? Yeah. So
Yeah. So
That's
David,
it.
I want to know whether this patient, when did the patient first report, or was it documented when she got that astigmatism? Like, was it right after surgery or
Yeah.
6 months after surgery?
Yeah,
Was it primarily
so I don't think
toric IOL?
this is the original letter, and the lens did not rotate. I think it was just, they got it as close, he put it in and left it.
Left it, yeah.
And I just figure, maybe it
Probably
rotated
the
or
primary
something.
surgeon had encountered some kind of zonular laxity
Yeah.
at the time of surgery as well, so he didn't try to position it perfectly, because when he was probably rotating it, he couldn't rotate it all the way.
Exactly. All right, thank you very much. While Lamar's hooking up, any other questions on dead bag? Use the mic.
Last year we reported one case of dead bag syndrome. In fact, that was a 25-year-old man was suffering from thalassemia major. So I operated both the eyes, and 2 years down the line in one eye, it presented with the subluxated this thing within the bag.
Huh?
So what we did in that case, what you suggested, instead of putting a segment, I put a lasso switch and then hooked it through a Hoffman pocket and centered the lens. But we don't know again the reason whether it was, though I did a meticulous polishing, but in other eye there was no displacement. So was it something to do with thalassemia major, where the oxygen supply or the capsule may be weak? We have no idea. So
She still may need to get a glued IOL after all.
So first of all, I have to give a big thanks to David Chang for coming all the way here. Ladies and gentlemen, let's hear it for David Chang. Those in the back, please come forward. You can even take this seat if you want, okay? So thanks Rohit for this lovely course which is jam-packed. I think it's because of people like Rohit and David Chang there. Now let's look at this patient here. Somebody had implanted a lens, PC rupture, left the lens behind. Years later, the patient has come to me. The problem was, this guy was a big shot in the garment, okay? Now what I told him was, you can see the lens is subluxed, sombering rings are present. So I told him, no problem, I'll make you all right. So let's ask the panel, and whenever I tell a patient like this, I'll make him all right, you can imagine how bad it will go. So panel, let's ask David perhaps, who is our guest here. David, we have a patient there with sombering rings present. So question comes, there is no capsule obviously there, there's posterior capsule is gone. That lens is badly subluxed. How do I remove those sombering rings now?
Yeah, so I mean, this would be a great case to just suture the haptics to the iris as one option, but when you have the Summerings ring that's that big, that'll get in the way. So you do have to try to strip it off, and you know, Sun Pek Chi has a beautiful technique where she uses an empty IOL cartridge, and if you pressurize the globe with viscoelastic, it's just everything wants to exit through that exit pipe, and that might be useful in this type of case.
But that can happen only if you have a support behind.
Yeah, that's right.
So Rohit, anything you can?
Sombering ring are the basic culprit in this, so those have to be managed. So if you manage them, then you know, the centering would be.
So let's see what we do. You see, this is a large eye, and a trick I tell everyone here is, when you have a large eye, do a small peripheral iridectomy. The reason is, you can come more anterior when you make your sclerotomy. Now look at that IOL, it is stuck to the iris also, because I told you this has happened some years later. Now I have dislodged that haptic from the iris slowly using the handshake technique. Now my game plan is very simple. I need to create a scaffold. So if I create a scaffold, then I can remove the sombering ring, because the sombering ring will not fall down. So now look what I'm doing. I'm now going to do a handshake technique, and I'm bringing that IOL from above the iris to behind the iris. So you see, one haptic is out. Now I'm going to do the second haptic. So whenever you have sombering ring where there is no capsule, remember, I need a scaffold there. But where will I put the scaffold? Unless you do a Yamane or a glued IOL, you can't do it, because you have to go behind the sombering ring. So now I'm doing the second haptic. Once I catch my second haptic, look at the tip, catch the tip and bring it out. So this is the glued IOL scaffold. Now once I have a scaffold, I'm tucking it into the chariot's pocket. Now I can attack the sombering ring. So the principle, if you see on the animation, is like this. I made my flaps. I'm going to implant my IOL inside. This is, I'm talking of cases, remember, there is no capsule there, but sombering rings are there. So there is no posterior capsule in the central area there. Now I have a chance to remove the sombering rings without them falling down, because please understand, these cannot come out with vitrectomy probe. Now you see I'm breaking the additions of the sombering ring from the periphery, bringing them to the center. Now you can use, as David Chang said, Sue's technique, or use a phaco probe, or just burp them out. Choice is yours. So here you can see, now once I have done that, I'm now trying to bring the sombering ring in front of the IOL. Once they are in front of the IOL, now you see my life will become much easier because I can now go in with the phaco probe and emulsify them. So this is the way I would suggest to manage sombering rings. See how many sombering rings there are. They are large, they are thick. You don't want them falling down. So this is the best thing. And I was so happy at seeing this case. And you know, whenever I'm happy like this, things don't go out well. So anyway, I try to complete this case as best as I can. And obviously the pupil is dilated. So we wanted to close it up with the 4th row pupilloplasty. Those who haven't done that, a very simple technique you can use where you pass the needle straight in. From the other side, a 26 or 30 gauge needle, railroad the two, bring it out, 4 throws, and it's game, set, and match. So here you can see I'm doing this. Remember, there are 2 ways to do this. It's important for you to know. I'm doing a vertical 4th row pupiloplasty. If you have an iris prolapse, do a vertical. You can do horizontal also in an iris prolapse. Let's say an IFIS case which David showed us on IFIS. But in this case, do always a vertical. Because if you do a horizontal, it will just bunch up. Anyway, coming back to this case, I thought use a vitrectomy probe. See the Purkinje image. That should be bang centered. And look at that Purkinje image. Don't look at the inverted Purkinje image. That is P4. Don't focus on that. Focus on the P1. Now, patient done. Very happy. And I was telling my wife, oh, I am so good. Post-op 1 week. I told you this is a big shot. Believe me, a real big shot he was. When working in the garment, 2/60. And then I realized the mistake. I had to change the IOL also. If you see in the beginning, the IOL power was wrong with the surgeon had put. I just missed that and I had to explant that IOL and put a new IOL. I use the same IOL. Now I had to sit for 1 hour explaining to the patient my mistake. And he said, why you made this mistake? Huh? I've come to you, why you making these mistakes? Huh? Huh? So now what am I to tell him? I have to keep quiet only, Baba. So anyway, now question comes, what to do, Rohit? What about you, Gaurav? The power was too much for me to do a laser on him, okay? The cornea is not that thick enough for me to do the laser. So, Gaurav?
Yeah, so you'll have to go for an IOL exchange, sir,
Yeah.
I think. There's no other choice.
So that's the only way I could do it is, but Kumar, there's a small problem here. I already have created a small pupil. Now, what would I do? Kumar?
Refer to Amar.
So now I have dislodged the haptics. This is just 1 week post-op, okay? And now I've dislodged the haptics. Now my problem is I take a scissor and I'm cutting this pupil. So I've enlarged it because I know I have to take it out. Now look what's happened to that haptic. It's got stuck in the iridectomy there. I'd created a peripheral iridectomy, remember there? So it's got stuck there. So I had to dislodge it. Now slowly take it out. Fix a new glued IOL. So again handshake technique. Now remember again I have to do pupilloplasty at the end of it also. So now I'm just fixing it back, fix the tuck. Now I have to close back. Now since I've got a cut here, I might as well do a horizontal 4th row pupilloplasty. See my Purkinje image, close it, and this is the iridectomy as you can see here. Look at the pre-op, look at the post-op, and you can see here 1 week post-op vision was 2/60. Then 10 days post-op vision improved to 6/12. I'll just show one last case also after this. And you see here in this particular case, this is the patient who had come to me. And why I'm trying to show you this case is, see this. Look at the HOA. And I tell everyone, start seeing the HOA of patients. Look at the holiday pentacam report. You'll see 6.358. Basically, it's a very high HOA. A normal HOA is 0.3. Now, the patient has a scar right in the center. The question comes, now how do you manage it? There's no capsule worth the name obviously there. Normally, we'll say go for a penetrating keratoplasty. And what we have started doing is cases like these, where you have scars, where you have even opacities, and I'm showing central scarring, which peripheral is easy. I'm trying to avoid a penetrating keratoplasty. So once I have made my scleral flaps, obviously I'll need to fix an IOL in this case. But in this case, what I wanted to show you here is, look at the peripheral iridectomy which I'm doing there. Once I have done that, I now go in, make my sclerotomy on either side. Once that's done, I will fix the glued IOL. Here you can see now, I've done the vitrectomy, I've got fluid going inside the eye. I make my main port, apply my vitrectomy probe there. And once that's done, see the haptic coming out. Once the haptic is caught, wait for it to unfold, pull it out. Now look at the handshake technique going inside. Transfer the haptic from one hand to the other, bring it out, and you can see the second haptic coming out. The issue here in this case, why I wanted to show you, is not to show only the glued IOL, but now look at the next step which I'm going to show you, and how do you manage this case, and how to avoid the penetrating keratoplasty in this case. So now you see I'm just going to rotate the trolley of the patient so that I can be comfortable. Now look, I'm going to start the single pass fourth row pupillasty. The advantage of the fourth row game is it's very easy. You can keep on repeating it as many times as you want. But the idea is simple. I need to make a 1.5 millimeter pupil. A simple rule you can follow is, we have designed also a holiday pinhole device. So keep it in front of the patient, made by Epsilon. What we do with the help of Jack Holiday, we made that. Keep it in front of the patient, ask him which pupil he likes. If he likes 1, we'll make the pupil 1. If he likes 1.5, we'll make it 1.5. But look at what I'm doing. As I'm doing slowly, you'll notice this pupil is becoming smaller and smaller. That small peripheral iridectomy is increasing, and if needed, I can even close that. Look at the endolimiter trick which I'm going to show you from outside, which helps me see better. As you can see, the pupil becoming smaller and smaller. Now, remember the step here is you need to have a vitrectomy probe. All your phaco machines have got very good vitrectomy probes. I tend to use the posterior vitrectomy system, being a retina person, but you can always use your phaco vitrectomy machines also with it. That small peripheral iridectomy had become large because I have pulled on that iris. That also gets closed because I don't want this patient to have any polychoria, things like that. Once that's done, now look what I'm going to do. I'm going to check the haptics. Once the haptics are in place, then take the vitrectomy probe. And you can see there, with the vitrectomy probe, decide and see whether you need to make that pupil correct size or not. It has to be centered around the Purkinje image, and you can see it's approximately in the Purkinje image there. Once that's done, I now close this patient down. Question comes, how did this patient behave? So the idea of this video was to show you, in cases like these bad cuts which you will see there, injuries, etc., you can do the glued IOL followed by the pinhole pupiloplasty as I'm showing here. And look at this patient here. Pre-op, post-op 1 week, patient improved immediately to 612. That is just to show you a coaxial photo of the same case. Thank you very much, Rohit, and thank you, ladies and gentlemen.
Dr. Gaurav, can you set up? How do you see fundus in such patients, and if required?
So basically, you can see the fundus 160 degrees plus of the fundus with either use the Mirante from Nidec, you use the Zeiss is there, the Optos is there, and the Heidelberg is there. These are all laser scanning ophthalmoscope which will give you a fantastic picture. But let's give a theoretical example. 5 years post-op, this patient developed a retinal detachment. I'm just giving it as theoretical. All you need to do is take a YAG laser and shoot, make that pupil bigger, and you're back to treating that patient retinal detachment even. One thing remember, these are young patients who have come, let's say, to us with an injury. The chances of success, and these cuts have also a lot of corneal vascularization. So doing a penetrating keratoplasty has its own headaches and its own problems. Even let's say if I had done a PK, without doing a pinhole, that patient's vision is not going to be exactly bang on track.
Should I start? Yeah. Thanks, Dr. Rohit sir. It's been a tremendous course so far. And let me see if I can keep the interest alive. So this is a hard brown cataract. Patient is quite senior, 75, 80 years old. And we've done a femto-assisted surgery here and some small LRIs as well. Now, as we proceed with the surgery, looks like a routine cataract surgery. We've gone with the femto-assisted steps. I'll run through those, and after that, making the side ports. These are calibrated side ports like Dr. Rohit likes to make as well for better chamber stability, get the that capsular tag out. Now when I try to rotate this lens, I realize that there is some zonular laxity, so I don't rotate it very vigorously. It's a hard brown cataract, and I decide that I have to very patiently get this out. And once the nucleus is out, I'm more comfortable. But see what happens. The moment I get that out, that whole bag starts pushing forward, and I decide that I need to get the cortex out. So you do see that irritating bit of small secretion on the cornea, so just ignore that. This is going to obstruct the view a little bit here. It's on the tear film. You can see it cutting across the cornea. It's an artifact basically. Now I'm proceeding comfortably and getting everything out, but then I get the bag out. So you can see that I caught the bag, and it was already a bag which was very lax. So in that hurry to get that last bit of cortex out, I have now done a reflux and I've freed the bag, and now I have to inject viscoelastic. So I infuse, get that out, and at this point I make the big mistake. I shouldn't have come out all the way. I thought that this would not cause a problem, but I should have seen that first step where when I had brought the infusion out, the bag had started rising up. So what should we do at this step? I've already made a mistake. What should be the next step? Anybody wants to volunteer? That bag is dehisced, over here. So should I go back with the infusion or do something else? Put in viscoelastic. Sorry? Port visco? Okay. Kumar, you want to do something differently?
No, I think put in viscoelastic and then put a CTR.
Okay. So let's see, I'll try to put in viscoelastic. Now you can see some movement happening there already.
Wow.
It's not the vitreous, but see what has happened now. I tried to put in viscoelastic,
From the
it
wrong
pushed
side.
the whole bag away.
It pushed the whole
I
bag
chose
off.
the wrong port to put the viscoelastic. I should have gone from the other side port, which was somewhere here. I went in from the wrong port. Now the bag has kind of, pushed away. I think now we can ask Dr. Amar what he wants to do at this point. So he would say, get the bag out and go ahead. So I'm going to see what we can do now. I go back to the other port. Now ideally my viscoelastic cannula should have been having a smaller gauge, because this gauge is, my side port is just 22.
That bag is quite fully gone.
Yeah, it's almost fully gone, but let's see. So I'm now going to go back and try to distend that bag and see. I'm checking for what's behind and see if there's still some scope, because I still have some cortex sitting there. Now I'm going into the bag and injecting viscoelastic, trying to inflate that bag. And now that I have the bag in place, now comes what David was trying to show you. I'm trying to put in a CTR. And I was seeing that video and I was saying that, that was a lesson in what I decided that that's the wrong way. And David, as you said there, trying to go the other way now. And now again, I find that it's pushing it away, trying several ways to bell the cat. And now I'm kind of pushing it in such a way that most of the CTR is in, but it's not helping. See, it's almost going to cause the whole thing to get broken. So there's no way it's going to go there. So what should we do now? David, you want to sort this out for me?
That bag is
I wish
officially
I had
dead.
that CTR injector you have, but I don't have
Yeah.
it.
No. Well, I don't think the bag's worth any support at this point, and other than maybe holding back the hyaloid face, but it's going to contract and crumple up. So I think you're going to have to plan on how to put the lens in without capsule support. So glued IOL would be an option.
Good option.
And then maybe you'll be able to grab the bag and extract it without doing a vitrectomy with forceps.
So, but I don't want to give up. I want to see if I can still put in the CTR. So I'm trying another direction. So that doesn't work either because it's not entering the bag. The bag is now a little behind. So I'm going from the other side port now. And I'm now going to do a guided kind of a thing. And this time on the SCRS, I'm going to pick up that injector that you showed. So it seems to be behaving so far. And so I got lucky, 4th time. And now I don't like to do what I'm doing right now. If I have to do this, I go in with a micro forceps and just go in and release it there, because sometimes it will just get dislodged. I was actually very keen to bring this cortex out first and then decide whether I want to keep this back. So I'm putting in capsular hooks now. a little too late in the day, but putting in that lens and then nudging it there. So the good thing is that if you have a CTR in the bag, of course this bag is almost gone, and I probably should have sutured it to the thing, but of late, in 5-10 years, when this patient comes back with a little bit of tilt, I just pass a suture around the CTR and just anchor it to the sclera. I've done a few of those, and sometimes it just they don't come back anyway. So this was kind of at the end of the surgery, still looking good.
Would you have fixed it to the
I should have, but
because it was
that's exactly what I said. I should have probably put in a CTS and anchored it at least in that one area. But since on OCT the IOL was perfectly, there was no tilt and everything, and there was CTR inside. So in 6 months or a year, if this patient ever, has a thing, usually they don't, but if in a few years they start with a dead bag or whatever, if they start kind of, having a small tilt, I just put one suture around the CTR because it's fibrosed by that time. And wherever it is, I just anchor it to the sclera at that point. And there have been only very few that I have had to. But sometimes I go in with a CTS and do a bipolar 2-point fixation.
Just one thing I suggest is, even if you're fixing a lens, I think a 3-piece would have been better off, no?
So 3-piece, of course, if I was not having a CTR, then 3-piece for sure, because then 3-piece you can do a glued IOL if you have
That's
to.
what
right?
I'm saying.
But
suppose by chance it falls down, I'm saying 5 years later.
So you with the CTR in the bag, for the capsular bag complex, if there's a CTR, you can just pass the suture around the CTR and fix it. So. Yeah, but if the bag went down, then the whole thing would have gone down anyway, right? So. I
David?
agree, but the putting a 3-piece into the bag in such eyes sometimes does so much more manipulation that you end up having a bigger situation and more kind of manipulation on the bag. So it was just easy to do it, and then with the CTR in situ, I find that the CTR itself works like a anchoring point for you down the line. In a few months, it's already fibrosed and nicely kind of stuck all around, and you can easily, with the IOL inside, you can just fix it. I mean, that's my way of doing it, but I completely agree that 3-piece lenses would be great, especially because if you have to glue them later on or you have to do something else, it's very easy to kind of use them for doing it. So I think that way is
Till how many hours, David, do you lock it by capturing a 3-piece, the optic, and with the haptic in the circle?
Yeah, I think this is a tough case because the CTR makes it look so good at the end of the case, and I think we're all concerned about will it stay that way. But you have a good approach, which is with that CTR, and you can always go back unless it really drops down. But the advantage of a 3-piece in the sulcus is you're really having the haptics contacting the ciliary body in 2 locations. So you're getting a little bit of almost like a scleral support without a suture, and the bag is keeping things up. The CTR is going to keep your bag from crumbling, but we already saw we're missing maybe 7 clock hours, 8 of zonule. So it's a good case because I don't think we have a consensus.
And how about locking it with
yeah, I mean, I think optic capture is very important here because the dialysis is so large. And if the lens is a really good point, a 3-piece in the sulcus, it just rotates till it finds that opening and then it goes through because whether rubbing or eye movement. So optic capture, because you did preserve the rexus, is and also keeps the bag from contracting. A lot of benefits to that.
So David, you would have put the 3-piece in the sulcus and did a posterior capture?
And then optic capture, yeah.
Perfect. So I'll just share this second case, and I think, this was an intumescent cataract, and I like to decompress these lenses from a new port. I don't like to go from the main port because that allows the viscoelastic to escape. So here, again, I'm making a mistake. I'm not stabilizing the globe. So I'm just trying to get in, and it's not a very sharp needle for some reason. So there goes. And there goes. I've created a radial tear in the capsule. It's all the way till so that was a sudden entry for the 26 gauge. You can see that it's kind of gone right till there. So now I wanted to decompress this lens, and I've created a new small flap, and I'm going to decompress it anyway, even though I know that there is a weak area over here, whereas there is a radial tear in the capsule. And now I want to kind of go around it, so I wanted to ask, Tushya can tell me maybe, I've done this in your OT once, if you remember, in live surgery, with the side port knife, and gone and punctured the capsule, and I had 3 people standing all around me trying to guide me how to recover that. So how would you do this one?
So I would probably take the needle and decompress it first in the center, and then make a small rexus in that decompressed area.
So
Like
I
how-
already decompressed it here, but
Yeah.
this thing is gone from here till here.
Yeah.
You know, it's like reaching.
So
about-
we can go around it and
Mhm.
merge that.
Right. So that's what I'm going to try. I'm just going to try and go around it. So oval rexus around that. See, I'm going from both sides now because I don't want to have a break. And then I'm just trying to go all around it. And see, I'm making a mistake. I'll probably need the Brian Little's maneuver over here, because it is still intumescent even after decompression in the periphery. So I'm going to go from the side port now and see if I can recover it. And yes, I can. So then I enlarge the rexus as well, because now I'm all around that area. And now I'll just get a rexus all around. So with this, I was able to save the day. And do we have time for one more, or I should stop? I think I've stopped. Yes, thanks. So that was, one or two funny situations. I had to change 2 of the videos because I thought somebody's already shown what I wanted to show, but so.
I think this is a nice case also for femto, actually. I'm not a fan of femto, but with this mature cataract, doing rexus is tough, and you have a femto available. I think rexus, this is a ideal case for femto, actually.
David, your take on using Zepto in these cases?
Yeah, we have in the United States, Zepto is another way to do an automated capsulotomy. It uses a nitinol ring with some electrical pulses to mechanically, almost like a cookie cutter, just create an instant rexus. So for those of us that have it, that's my favorite for a white cataract. Yeah.
So I would like to thank Dr. Rohit for giving me this opportunity. So I'll be showcasing few cases. So first is this case. So everybody, why did we have an Argentinian flag sign here? So I would like to ask the panelists their comments, and then we can move on.
It's the intralenticular pressure
Okay.
plus the posterior push. So it's a huge.
Dr. Gaurav, what do you have to say? Anything else you want to add?
So decompressing small.
So you went from the main port and you were trying to create the
Yeah,
rexus,
that's
right?
one more point, yeah.
Yeah.
So I would have just not used the main port for any instrumentation to go inside. I would have gone from a side port which was not allowing, and a heavy viscoelastic, maybe a soft shell kind of a thing to have good tamponer, and then I would have probably penetrated the capsule somewhere in the mid periphery where the pressure is the least, and then started maybe created a very small quick rexus there, and then aspirated some of the cortex from there, and then gone on to do the rexus again.
So this was a very old video with a very low ACD. So of course, as rightly Dr. Gaurav mentioned, it was a non-calibrated incision. So I had used a viscodispersive, and I didn't do a closed chamber decompression. So ideally, the AC pressure should be more than the intraventricular pressure whenever you are dealing with those cases. And in this case, it was lower, so there was an efflux of OVD with the radialization. So how do we prevent it? So there are numerous ways, like preoperatively, whenever you have an intumescent cataract, you can see the ACD, which is usually low. You can compare it with the other eye. The lens thickness is more. And then, of course, with the preoperative interior segment OCTs, as we are using it in all the white intumescent cases, we are able to plan it preoperatively. And then with the slit lamp examination, in biometry, you often see those 2 or 3 spikes. So the basic fundamentals are that in this intumescent cataract, you have compartmentalization. There is high intralenticular pressure. So it's there in the intumescent cataract, whereas in Morgagnian cataract, because of the freely mobile nucleus, so there is no compartmentalization. So there are less chances of radialization in Morgagnian cataract. So our aim here is to increase and equalize the pressure in the interior chamber, and do not allow the AC pressure to decrease or suddenly decrease. Use calibrated incisions to prevent the efflux of OVD from the AC. So how do we decrease the posterior pressure? We can use IV mannitol which can cause temporary removal of fluids from vitreous gel. You can use lid pressure like Jaffe speculum, which gives you less lid pressure. Use hylace to spread the anesthetic agent used for the block. People do dry vitrectomy also before in such cases, or you can do flax by taking the advantage of closed chamber decompression. So in this case, like what we usually do is we make a microincision if possible, like a calibrated one. We can make a partial microincision initially if you are doing it from the main port, or as Dr. Gaurav said, we can use the side port. So first step is do a 30 gauge needle decompression. So what we do here is a bevel down 30 gauge needle from the peripheral cornea. It is entered and it is taken into the central part of the lens, and it is decompressed in that area. So simultaneously decompression with the 30 gauge needle is done. And then you can see we have an intraoperative OCT. So you can see here how with the help of 30 gauge needle, you can see in the OCT the central area is being decompressed, and you can see that there is a fluid area in the paracentral part. So now, as we know that there is decompression in the central part with increased intraventricular fluid in the paracentral area, so our next step is to make a small central capsular excess in the decompressed part. So with the initial nick through the calibrated main port, we make a small capsular excess in the central decompressed part. So once it is done, so now there is still intraventricular pressure in the paracentral area. So how do you manage that? As Professor Chi has shown capsule milking. So this is a very nice way where with the blunt cannula you can gently massage the paracentral area and you can take out the fluid through the center. And then after that, debulking and decompartmentalization is done with the same cannula. You go in and you aspirate it, as there is still some amount of fluid in the posterior compartment. So you go in, you gently tap it, and you take out the posterior, the fluid from the posterior compartment. So now the incision, the calibrated one, is made, and with the gentle capsule milking, the remaining fluid from the paracentral area is taken out. And with the same cannula, it is aspirated. The remaining fluid is aspirated by a gentle tap on the nucleus, so that the remaining fluid, even from the posterior segment also, posterior compartment also comes. So now CCC enlargement is done, a nick is made, and you'll be surprised that all these capsules then they behave just like normal capsule, and you can make a normal 4.5 to 5 millimeter excess comfortably. So another case where this is a case which was being done by one of our fellows, where he was trying to enlarge the rexus and inadvertently ended up into an anterior capsular tear. So you can see here there was, so as a flap motility sign, whenever you have an anterior capsular tear, and if the flap stops fluttering, you should be aware that there is some catastrophe which has happened. The tear has gone posteriorly, but the doctor, the fellow who was oblivious of the fact of the flap motility sign, kept continuing phacoemulsification, and the flap had stopped fluttering, and it led to a nucleus drop. So what was the root cause analysis in this case was there was an anterior capsular tear, and he was using high fluidics, which led to that anterior capsular tear becoming into a wraparound tear. And then the separational forces which was being used by the doctor were wide separational forces, and he was not aware of the flap motility sign. He should have stopped at that time and converted into an SICS or ECC. So what would you do when you have such a situation where the capsular tear has gone into an Argentinian flag sign? First plan is not to you should not panic. Always evaluate the extent of tear using flap motility sign and use safe phacoemulsification techniques. So how do you evaluate the tear extent by flap motility sign is that everted and fluttering flaps are pre-equatorial in nature. But once this flap extends beyond equator, it stops fluttering and becomes inverted and becomes a wraparound tear. So that is the end point of safe phacoemulsification, that you have to stop at this time and convert it into an ECCE or SICS. So this case was a case of wide intumescent cataract which had an Argentinian flag sign. So how do you evaluate first? The first step is inject viscoelastic and see the motility of the flap. It is everted and fluttering, so this means it is pre-equatorial. The second step to evaluate is you can take your probe in with the fluidics, you can see how the flap is fluttering and is everted. So this means, this confirms that it is pre-equatorial. So how do you, when you are continuing the phacoemulsification, you have to continuously have a continuous vigil on the motility of the flaps. So you can do it intermittently, or what we do is we train our assistants, so they also glue themselves on the screens and they see the motility of the flap, and because the most important thing is you have to see all the flaps, it's not only one flap. So what all safe phacoemulsification techniques you have to use is low IOP phacoemulsification, slow motion as being described by Dr. Abhay and Dr. Bob Washer. Then you need to have stable chamber settings. The site of incision, if you can make it slightly away from the tear or perpendicular to the tear, would be better, as it prevents any furthermore stress on the bag. Then you can create an additional rhexis extension. There should be no pushing of nucleus while you're trenching or while you're doing sculpting. Avoidance of wide separational forces, and whenever you are using those separational forces, you have to use it in the direction of the tear. And if possible, you can also do a supracapsular emulsification. So talking about the prerequisites is, first is you need to have calibrated incision, whether it is side port or main port, because you don't want to have any fluctuations. Active fluidics, I have no financial disclosure, is one more thing, and then use of slow motion phaco is also very important. So aim here is to have minimal pressure difference between the interior segment and the posterior segment, because if you have minimal pressure difference, so there's no pushing back of the nucleus, and the chances of an anterior capsular tear becoming into a wraparound tear decreases. So what happens when you're using high fluidics? So this anterior capsular tear, because of the high fluidics, there's an increased chance of becoming into a wraparound tear, whereas in low settings, the minimal turbulence and low pressure fluidics makes this anterior capsular tear does not beyond the equator becoming into a wraparound tear. My machine settings, usually in these cases, I reduce my parameters, as Dr. Rohit also showed it before, with the low IOP of 20, low vacuum and aspiration flow. And for my quadrant mode, I slightly, if it is a hard cataract, I increase the vacuum and the power also. So coming to this case, so first is always remember low IOP, slow motion phaco, slow sculpting, slow division of the nucleus, which is very important, and separational forces should be non-wide separational forces in the line of the tear to prevent any stress on the anterior capsular tear. Slow rotation is very important. Aim here is to have a minimal pressure difference between the anterior segment and the posterior segment, so that there are minimal chances of this anterior capsular tear going beyond the equator. The minimal pressure, minimal turbulence and low pressure fluidics helps this anterior capsular tear in preventing going beyond the equator. And slow motion phaco is also another thing which is really important, which has to be kept in mind, as described by Bob Washer. So in this case, the nucleus was a little on a harder side. So what I usually do is, because I usually avoid doing a supracapsular phacoemulsification in these cases, as patients, they really want to have crystal clear corneas and good outcome the very next day. So I use a small technique which we have published also, chopper shield, where we strategically place this chopper in front of the nuclear piece between the phaco tip and the endothelium, and we do a slow motion phaco with, so that there is less nucleus chatter and less damage to the endothelium. And with this, we continue phaco. Always remember to inject viscoelastic before taking out the probe, because that can also lead to an extension of the anterior capsular tear. And you can see here, I'm continuing IA with, again, low phaco parameters. And if I'm doing an IA close to the anterior capsular tear, I usually do a dry aspiration as by Gill's technique. The rhexis is regularized, and the one thing which I could have done was I could have placed the haptics opposite to the site of the anterior capsular tear. So thank you so much. So the last thing which I want to mention is that you can have a false positive anterior capsular tear also. So it is really important that all 4 flaps should be everted and fluttering, so you can take the help of your assistant and you can also intermittently visualize the motility of the flap. And false positive flap motility sign is also seen in pre-existing PCR, so it has to be ruled out. Thank you so much.
I would like to mention about the flap motility sign, which the Rohit Om Prakash family have brought out, is fantastic, because it really is a great sign which can really save you whether you want to convert or not convert.
Thank you.
Thank you, Dr. Tushir. I would like to thank David for making it, Dr. Amar Agarwal, and Dr. Kumar Doctor, and the delegates for making it to this IC. I hope we have been able to justify the title of our course, which was wherein we have tried to analyze, do the root cause analysis so that we can be better off when we are next time in the OR. Thank you so very much, each one of you.